I will just start the talk. I just want to thank the MND organization for inviting me to give this talk. And I also want to thank Dr. Chanyao and Dr. Deborah to support this talk. I'll be sharing some airtime with Dr. Deborah later. I will start the session today. So our topic for today is secretion management in MND, motor neuron disease. So how am I going to carry you through this talk is to understand what is the problem with this MND patients. So to understand that, we will try to understand the mucus production and transport first, understand cough, and how do we assess cough. And once we understand how to assess cough, right, we will go with management. First management will be siluria. And then based on the cough assessment, right, if the cough is intact, how do we manage this patient? If the cough is not impaired or is not intact or is impaired, how do we manage these patients? And finally, right, we will try to see how do we apply the secretion management with NIV, because most of the patients will be in NIV. So that's how this talk is going to be going on. So we all know our respiratory system is very complex. I just wanted to introduce this slide first. So we have 23 generations. So if you want to handle this system right, you need to have a very good mechanism where the secretions are produced in your airways and it is moved through these 23 generations and it is cleared through your mouth or you swallow it. So that's how complex it is. So how do we really clear the secretion? We just go on. First thing to understand is how are these secretions produced? There are many shells in our airways, serous shells, goblet shells, Clara shells, type 2 alveolar shells. And these are lining the airways from your upper airways to your lower airways. So every cells has different functions. They produce secretions. They also protect your airways. So these secretions lubricate your airways, and somehow these secretions has to be cleared from your airways. We have two mechanisms to clear your secretions in your airways. One is your mucociliary clearance, and the second one is your airflow clearance. We'll talk about mucociliary first. So normally if you see a mucus, right, it has two layers. The first layer is your sol layer, and then you have your mucus layer. So I'll just point to the diagram here. The first layer is your gel layer here, and second is your sol layer. So the gel layer is a little bit mucoid, so it catches the dust particles. And here in the sol layer, right, it's a bit fluid. And this is where the cilia sits. And the cilia keeps constantly beating, and it beats towards your mouth. So this mechanism constantly happens in your airway. So the airways produce mucus, and this cilia keeps moving this mucus towards your mouth. And we are not conscious of this process, and we swallow our secretions. We don't really cough to clear our secretions. We just swallow our secretions, and it is without our knowledge. So that's how airway is maintained clean. This is the first mechanism, mucociliary clearance. And just to highlight here, this mucociliary clearance is more predominant in your peripheral airways. Peripheral airways is towards your alveoli, and it is less of effect in your central airways, which is near your trachea and in your upper bronchi. So if I go down the next slide, the next mode of transport is your airflow. So once this peripheral airways use the ciliary mechanism to clear the secretions, it goes towards your trachea. From there, right, if you want to clear the secretions, you need a kind of a powerful source. Sometimes you cough if it is excess. If not, you just swallow. The cough mechanism works like this. If you want to clear that secretion, the airflow has to be powerful. So it has to narrow the airways, and there should be a pressure pushing that phlegm out. So these two has to combine, and this is more enhanced in your central airways compared to your peripheral airways. That's why cough is very, very important to clear your secretions from your central airways. So these are the two mechanisms we have to clear our secretions from our airways. The first one is your mucociliary, and the second one is your airflow. Airflow is more enhanced in your central airways compared to your peripheral airways. So this is our basic physiology. So if this basic physiology works, we have no problem. Even in a normal situation, or even if you get some flu or some pneumonia, is no problem, because we have this normal physiology working, and then we are able to clear our secretions, and our airways are protected. But what happens in a motor neuron disease? So just to give you a brief idea, what is motor neuron disease? It affects your motor neurons in your brain, as well as in your spinal cord. And then in turn, it affects your muscles. So your muscles get weak. So that's what is motor neuron disease. So if I bring this into a perception of a respiratory system, right? So you have respiratory muscle weakness. So when you have respiratory muscle weakness, there are two things which can happen. One is your ventilation is going to be reduced because you don't have enough strength in your respiratory muscles to take in a deep volume. So that is how ventilation is affected. When ventilation is affected, what is the result is you have hypoventilation. And then when you have hypoventilation, you need to support this. That's where NIV comes in. So today we will not be talking about that. So today our focus will be, right, the second part. When respiratory muscles are weak, right, your cough mechanism is also going to be affected. So when your cough is affected, you have retention of secretions. And today, all our time will be spent, how do we enhance this secretion clearance when this cough is weak? So we will just go on. So as I said, now in MND, there are two issues with respiratory system. One is ventilation and one is weak cough. Today, our session will be focusing on weak cough. So everybody knows what is cough. I don't need to teach you what is cough. I just wanted to, for completion's sake, I just put this definition here. An effective cough is a protective mechanism to protect against respiratory tract infection. So it can be defined in many other ways also. This is one way to define it. So as I said, in a normal person, there are two ways to clear secretions. One is your mucociliary and the second one is cough. But with NMD, the mucociliary clearance may be intact, but the second mechanism, which is your cough, may not be very, very good. So that's where the problem comes. So they are going to have some problem clearing their secretions. Cough is just not just coughing like that. It has some stages. We need to understand that so that we can appropriately apply our intervention to these patients. So if I go through these three stages, right, one is deep inspiration. Before you cough, right, you need to breathe in. Then your glottis closes. I just point here. This is where your glottis closes. This closure is a very short second, 0.02 seconds, but it is enough to build up the pressure. Your abdominal muscles contract, the glottis closes, the thoracic pressure is increased, and then it suddenly opens, and that sudden opening expels that air. Glottis open and then expels, and that's how your phlegm can come out. So all this is happening with very fraction of seconds, and we don't know. But all we know is we just hear that. We thought only the last phase is coughing, just that sound. But before that sound to come, there are so many things happening. So we need to understand that is what is cough. There are many stages in cough. So if we know there are many stages in cough, right? If you want to assess cough, we may have to spend time assessing all the three stages. So just to know where is the cough affected? Is it because the patient is not able to breathe in a bigger volume? That's why the cough is affected. Is it because the bulbar is not functioning well? So the patient is not able to build up enough pressure. That's why the cough is affected. Or is it because the patient has a poor expiratory muscle? That's why the cough is affected. So we may have to understand where is the cough affected. So I put this slide here just to give you a brief idea. How do you assess different stages of cough? For inspiratory muscle, we will just go on first. For inspiratory muscle, is very easy. We can either use vital capacity or we can use NIF, negative inspiratory pressure, or maximal inspiratory pressure. So I think your hospitals will have this kind of devices to measure your inspiratory muscle strength. Whichever device is available, you can use. Basically, we need to know whether the inspiratory muscles are good or they are weak. So I put some normal values here. This MIP normal value is minus 60 to minus 90. Anything below that, you can suspect there is some inspiratory muscle weakness. So that's your MIP. Vital capacity, we all know this is a gold standard. If vital capacity is decreased, we know inspiratory muscles are weak now. According to the journal, if it is less than 50% predicted, you should assume that this patient has quite a significant weakness and something has to be done for the inspiratory muscles. So they also say you should be able to generate 3 times your tidal volume for your cough to be effective. Just a rough guide. So that's how you measure your vital capacity. So this is how the first assessment goes, inspiratory muscle. Very simple, easy, available is your NIF. Or if vital capacity measurement is available, you can use a vital capacity measurement. So know your inspiratory muscle strength. That's your first step. I'm just going to jump to the expiratory before going to bulbar. Expiratory, I think we all know this. We use this for asthma patients also, the PCF, just to see how much the airway is patent. If it is bronchospasm, then this is going to be reduced. But the same can be used to check the expiratory muscle strength. So there is a difference between peak cough flow and peak expiratory flow, which I'll be explaining in a short while. So usually we measure peak cough flow. Peak cough flow is like you take a breath in and then you you cough and see what is the value. The normal value is around 360 to 1200 liters per minute. And the point to note here, the numbers are very important here. We have to keep these numbers in mind. Anything below 160 is a sign of weakness. Already the patient is having some significant weakness to clear secretions. But they also say 270 is needed to have a very, very good clearance. So these are some numbers we need to know. So now we have SS2 components. One is your inspiratory muscle strength, and second one is your expiratory muscle strength. The in-between component bulbar is the most difficult thing to assess. It is not very easy to assess. I'm giving you an easy way to assess. Just focus on the right side first, the table here. So just now I said peak cough flow, peak expiratory flow. What is the difference between peak cough flow and peak expiratory flow? So I've just explained this with a video first, and then we come to this. So the first video is going to show you what is peak expiratory flow, and the second video is going to show you what is peak cough flow. So the first one is you breathe out into your peak cough flow, and then the second one you cough out. So you can see the difference. There's a difference in value between the two. So here is around 400 plus. Here it's more than 500. So why there's a difference between peak expiratory flow and peak cough flow? I'll just go back to the previous slide. So if your bulbar is intact, your peak cough flow is going to be higher because you are able to build up nicely pressure. Peak expiratory flow is done with an open bulbar. So it's open glottis. So you can just blow out. So that is going to be slightly less compared to your peak cough flow now. So one way to understand whether the patient is having bulbar involvement is right. If peak cough flow and peak expiratory flow are of the same number, then you know there's some bulbar involvement. This is one easy way to clinically assess whether this patient is having bulbar involvement. But we have other ways. The patient will have swallowing difficulties, drooling of saliva. All those is also signs that the bulbar is already involved. Okay, on your left-hand side now, I'm just going to talk about MIC. So I'm just going to introduce this because later I'm going to use this word in my slides. MIC is the maximum lung volume that can be held by air stacking. So this is another way to assess bulbar. So I just go through this graph here. We are measuring vital capacity as MIC. Normally with the NMD or motor neuron disease, vital capacity keeps going down because it's a progressive disease. But you can still maintain your MIC. So what is MIC? It's an artificial vital capacity. The patient cannot take a bigger volume, but you can stack the patient's air inside. If MIC is greater than VC, like maximum lung volume is greater than vital capacity, means that the bulbar is intact. If you cannot achieve a greater MIC than VC, then the bulbar is not intact. For air stacking, right, you need to stack, means the bulbar has to be intact. So this is one way to assess bulbar. So there are two ways to assess bulbar. Either you can measure MIC and see whether it is greater than VC, then the bulbar is intact. We can assess peak cough flow and then see whether it is greater than peak expiratory flow. If peak cough flow is greater than peak expiratory flow, then bulbar is intact. So this is two ways to assess bulbar function clinically. So these are some values I've just shown. There's a difference between peak expiratory flow and peak cough flow. So now with this assessment, right, so how do we put this into application? So this guidelines is from the Canadian Society. So they have used peak cough flow as a guide. So when the peak cough flow is greater than 270 liters per minute, right, this is where I said the cough is intact a little bit. So patient just needs clinical monitoring. If peak cough flow is less than 270 liters per minute, that's where your assessment, whatever assessment you have done, will kick in. But if you think it is starting because the inspiratory muscles are weak, then they ask you to initiate LVR, lung volume recruitment, or breath stacking, which we will be talking in detail later. Then with that, also the peak of flow is less, then you initiate manually assisted cough, which we'll be talking later also. But with initiation of LVR, right, you achieve a greater than 270 liters per minute, then you again go for clinical monitoring. So even with LVR and manually assisted cough, the peak cough flow is less than 270 liters per minute, then you go for cough assist. So this is how you have to manage your patient. Rather than straight away going to cough assist, we need to use your peak cough flow value and then start with LVR, manually assisted cough, and then go to cough assist. So this is a good guide. So with this, right, I'm just going to carry on with my presentation, seeing whether the patient is having an intact cough or the patient is having an impaired cough. So before this, right, I'm just going to allow Dr. Deborah to talk about siluria. So siluria is a big problem with NMD patient because it starts with your mouth. So if your saliva is not managed well, right, it's a big problem. So Dr. Deborah will be talking about siluria. Then I'll come and talk about how to manage your secretions from your lung.
Okay, so I'm just going to touch briefly upon the management of siluria. I do understand that there are quite a number of palliative care physicians here. So I think you guys will be probably more expert than me in this, but I'll do what I can. So just to explain and give an introduction about it, basically siluria is actually the unintentional loss of saliva through the mouth, and it should not be confused with hypersalivation. Hypersalivation tends to be more common in certain motor diseases such as Parkinson's disease. And at least 25 to 42% of patients, possibly up to 50% with ALS actually experience siluria, with almost half having poorly controlled symptoms. So the main cause of siluria in ALS is actually the inability to swallow secretions due to tongue spasticity, weakness of the orofacial pharyngeal muscles, and also the loss of oropharyngeal coordination and function. And here you can see that our salivary glands are actually innervated by both the parasympathetic as well as the sympathetic nerves. And so you can see that that from the first one, you can see that there's this SSN, that's the superior salivary nucleus, and followed by that, there's actually the nerve that runs through the facial nerve, the ganglion, and then it goes down to the chorda tympani, and then it supplies both the sublingual glands as well as the submandibular gland. And then also we have the inferior salivary nucleus, which is in your medulla, and it actually supplies, it goes to the otic ganglion, and then it goes to the parotid gland. So you can see that all the glands are actually supplied by both parasympathetic as well as sympathetic fibers. And looking at this diagram, which is a bit more simple diagram, you can see again that there's a sympathetic as well as parasympathetic centers. And the sympathetic part, there's actually the sympathetic salivary center coming from the upper thoracic segments of the spinal cord, going to the supracervical ganglion. And you can see that actually for each gland, the submandibular gland actually mainly produces serous mucous saliva. The sublingual gland mainly mucous saliva, as well as the parotid gland, it's mainly serous saliva. So you can see that for actually the submandibular gland, it mainly produces unstimulated saliva, but for the parotid gland, it usually produces saliva under stimulation, such as chewing, and it is actually responsible for the main production of saliva, which is 66% of the total flow. As well as that, we must know that actually the 3 pairs of the major salivary glands actually produce about 95% of saliva, and adults actually produce 1.5 liters of saliva daily. And secretion will be modulated, as I mentioned, by the ANS, which is the autonomic nervous system. So serous secretions are actually controlled mainly by the parasympathetic, cholinergic, as well as sympathetic alpha receptors, while thick secretions or mucoid secretions are produced mainly upon activation of the sympathetic beta receptors. There are certain tools that we use to actually measure siluria severity. The main one that we know of is actually the ALS FRSR, the 5-point scale on salivation, whereby normal is +4, slight but definite in excess of saliva in the mouth, and may have nighttime drooling is +3, moderately excessive saliva may have minimal drooling is +2, marked excess of saliva if some drooling is +1, marked drooling requiring constant tissue or handkerchief is 0. There's also the oral secretion scale, or OSS, which was actually developed by Cazzoli and colleagues. And it actually showed that they actually did a study that showed the OSS score for, they tended to tolerate NIV and survive longer than patients with a score of less than 4. There's also the salivary scoring scale, or SSS, that was initially developed for Parkinson's disease and children with developmental disabilities. They did a validation study. So both the OSS as well as the SSS scales, they actually have high inter and intra-rater reliability. The SSS may actually be more sensitive because there's a wider range of salivation degrees. So how it is basically score 1, it is dry, never drools at all. Score 2, mild, only the lips are wet occasionally. And as we go on, there's up to score 8, which is profuse salivation. On clothing, hands and objects, they become wet occasionally. There's also up to score 9, which is that it is profuse. The clothing, hands and objects become wet frequently. The last one is actually a clinical saliva scale, which is a patient-reported measure for salivary impact. And it strongly correlates with a Likert scale of measure of salivary severity. So it's mainly useful for research because we do find that the impact of salivary over a patient's life is actually a better outcome than its severity, as the two may not always correlate. This is a generic approach to oral secretions in neurological disease. So basically what we do is we need to assess the symptoms, reverse any identifiable factors, record the symptoms on some of the scales as I mentioned previously, follow the thin, thick or both pathways as appropriate, and also look at symptoms, whether it's mainly coming from the anterior or posterior. So for thin secretions, usually we start off with certain conservative measures, adequate hydration, oral rehabilitation. If they have Parkinson's disease, we will optimize their dopaminergic therapy. Then followed by anticholinergic therapy, whereby we usually start low and titrate up. We usually warn about side effects, and they will usually improve after 2 weeks. If there's Parkinson's disease, some of them do consider skipping straight to Botox or botulinum toxin. So for Botox, usually we have to refer to specialist services, such as our neurologist or rehab. And the approximate total dose would be about 2,500 units of type B or the type A equivalent. So if we are planning to inject the submandibular gland, we will need to consider ultrasound guidance. The last therapy would be radiotherapy. And it's usually what happens is that there are some side effects which I'll go through later. So we also have to consider whether the radiation exposure is acceptable, because with a long-term exposure, there are some small risks of developing malignancies, although because of relatively life-limiting scope of ALS, usually that may not be much of a concern. For thick secretions, we will go through the medications, simple conservative measures. We will provide mucolytics such as acetylcysteine, consider need for suction and nebulizers. And then followed by all this, we will reassess, see whether they develop any new thick secretion problems or new dry mouth. And then we go back and try to address the thick secretions as well. So there were quite a few rehab as well as prosthetic treatments, but mainly there's this chin support for falling head and chin. There was also a case report of a lip sealing intraoral prosthesis, which was performed by actually a dentist. You can see the diagram over here. So actually it did help to some extent to actually control the drooling, but there's only one case report. And then there was also 3 other therapies, the oral motor therapy, as well as behavioral modification and oral facial regulation therapy. But again, these therapies are mainly for pediatric patients with neurological deficits, and the applicability to ALS is actually unknown. So now we come to anticholinergic medications, and we know that saliva is actually decreased by blockade of the parasympathetic stimulation to salivary glands. So no study has actually compared the efficacy of different anticholinergic medications for salivary. A randomized crossover trial done in patients with Parkinson's disease with oral glycopyrrolate, 1 milligram 3 times a day, actually showed that there was significant improvement in the mean salivary score and no significant differences in adverse events. sometimes in severe cases, we may actually prefer sublingual or transdermal forms. And a small crossover double-blind study by Odachi et al. Actually assigned 10 patients with ALS to scopolamine or hyoscine or placebo patches for 1 week. So they found that the mean volume of daily oral suction actually decreased with scopolamine, but no significant difference between both groups in terms of the VAS or the saliva item of the ALS-FRS revised. So some of the routes and medications are in this table, which you can possibly follow. So for amitriptyline, sometimes they start with 10 milligram ON, or they can start with 10 milligram TDS. They can go all the way up to 150 milligrams in total dose. So some of the side effects, I'm sure you all know the anticholinergic effects, which are usually drowsiness, mydrosis, cycloplegia or blurred vision, tachycardia, arrhythmias, and flushing, as well as constipation and urinary retention. So these are the anticholinergic effects. But apart from that, there are also some other side effects such as REM sleep abnormalities, seizures, orthostatic hypotension, nausea, vomiting. For scopolamine or hyoscine, we can start off with a 0.5 to 1 or 1.5 milligram patch every 3 days or every 72 hours. And the side effects include dermatitis, eye dilatation if there's contamination of the eyes, and rebound cholinesterase activity if discontinued. For glycopyrrolate, we start off with 0.5 milligrams BD. We can go up to about 1 to 2 milligrams TDS. There's also quite an interesting case report, okay, that I'm just going to share with you. I don't have the slide here, but I just wanted to share with you by this doctor called Cooper Knock. And basically what they did was, he actually gave sub-Q glycopyrrolate 600 micrograms over 12 hours. And it was found that actually the NIV tolerance after giving that dose of glycopyrrolate actually improved from less than one hour to 6 to 8 hours every night. So actually that was quite an interesting thing. And it suggests that further studies may be considered, with glycopyrrolate sub-Q version as well, but it's only one case report. The other thing would be atropine. So they can give sublingual drops about 0.5% to 1%, 1 to 2 drops 4 to 6 times a day. Of course, there are also some side effects to that, including hypotension, hallucinosis, as well as delirium. So to date, only one randomized double-blind study of Botox B for sialorrhea in ALS by Jackson et al. In 2009 was done. So 20 ALS patients were looked at, and either 2,500 units of BTXB in 1 ml normal saline or normal saline given via the electromyography needle. So for there will be 500 units per parotid gland, which means 0.1 mils or 250 mils in 2 different sites of the gland. And then there will be 750 units per submandibular gland. And so at 4 weeks, there was actually a significant difference in patients' impression of improvement in drooling. So this was actually statistically significant at 2 weeks and 4 weeks. At 8 weeks, there was also still a difference, although this was not really statistically significant. And all the way up to 12 weeks, there was still some difference in terms of the improvement in the global impression of change by the patients. So there are 2 types of Botox, and one is Botox A, and one is botulinum toxin B, which is neuroblock. And so usually they tend to use type B, but it depends on what is available as well. For type B, we do know that there are more autonomic effects, and sometimes they may have higher immunogenicity, meaning that there might be antibodies that develop to that toxin as well, making it less effective with later doses. So for the dosing, some of the common doses include 100 mU of Botox or 2,500 mU of neuroblock. And doses usually are divided between the submandibular and parotid glands with a greater fraction to the parotid gland. We sometimes use ultrasound guidance for accurate delivery, although landmark guided can also be largely quite safe. Outcomes of treatment, usually the effects last about 3 to 6 months, okay, usually about 3 months. Disadvantages would be a dry mouth, xerostomia, thickened secretions, and difficulty chewing. We also do know that patients with MND, they may have a slightly shorter benefit of duration compared to those with Parkinson's disease. And this is how they do it by landmark guidance. So for the submandibular gland, if you look at the one on the left, they actually look at the midpoint between the angle of the mandible and the tip of the chin. So they actually inject one finger breadth medial to the inferior surface of the mandible with a direct needle straight upwards and as close to the middle surface of the mandible as possible. And for the parotid gland, it's usually 1 cm anterior to the midpoint on the line connecting the tragus to the angle of the mandible, approximately at the side of the earlobe. Okay, and followed by that, if the Botox doesn't work or the botulinum toxin therapy does not work, they actually can consider things like radiation therapy, which can be either electron-based or photon-based therapy. So just to let you know how it works very quickly. So ionizing radiation is actually energy that is sufficiently strong to remove an orbital electron from an atom. And this radiation can be in the electromagnetic form, such as a high energy photon, or particulate form, such as an electron, proton, neutron, or alpha particle. So in a retrospective study by a guy, there's actually a good response to radiotherapy observed in 65% of patients. But we did know that 4 of 13 of the patients treated with photon-based therapy actually experienced some acute toxicity symptoms or delayed reactions 1 month or 3 months after. But conversely, none of the 8 subjects treated with electron-based therapy actually had side effects. So this is actually just a table to show you some of the studies that were done. I mean, they are not randomized studies, and mainly they are retrospective studies, so that you can see that there are many different doses or many different types of grays. So grays is actually the basic radiation unit, the absorbed dose, and it's the amount of energy in joules absorbed per unit mass. Okay, so you can see that the total 19.1 grays in 5 fractions in 17 days for Bori. Then there was also single fractions of 7.5 grays. But we did find that all of them, there's always improvement. Okay, is for example, for the Anderson study on the bottom, you can see that 17 patients actually had great improvement, but they started to drool after about 4 to 6 months. So we also know that there are patients that are on continuous NIV that cannot tolerate being off the NIV device for very long. And there was this pilot study by Amador et al., okay, in France, of 5 ALS patients. So they looked at the efficacy and tolerance of a protocol of RT designed for patients requiring mechanical ventilation while in the decubitus position. And they did treatment with the linear accelerator, so 6 megavolts of photons in both submandibular glands, as well as 2/3 or the lower 2/3 of both parotid glands. Now, why do they choose the lower 2/3 of both parotid glands? And if you can see that from my previous slide, and if you remember, the parasympathetic innervation is mainly to the lower 2/3, and the sympathetic is to the upper 2/3. So what happens is that, okay, just to show you again, so sorry, I'll go back to that. So you can see that actually, the sympathetic is actually at the lower 2/3, and the upper part is mainly the parasympathetic fibers. So you can see that if you radiate the lower part, the sympathetic fibers, you try to prevent, very mucoid secretions. Whereas if you had radiated or you had given radiation therapy to the top part, the parasympathetic fibers, you may end up with more thick secretions because the sympathetic fibers tend to stimulate more mucoid salivary secretions. So that's possibly the reason why usually they tend to target the lower 2/3 of the parotid glands. And also, basically, they were in a 30 degrees decubitus position, max period of 10 minutes. So there was this thermoplastic mask that you can see on the right in figure A for RT that was specifically designed to fit the facial mask of the NIV with a large opening over the mouth and nose. Okay, there's one large prospective study by Assolin in 2014. Also, they did the 6 megavolts of photons and to the submandibular glands and the lower 2/3 of the parotid glands. So the total RT dose was 10 grays in 2 fractions or 20 grays in 4 fractions. And they did find that all the patients had improved at the end of RT, and a significant lasting salivary reduction was actually observed 6 months after RT completion. But there were more patients with a complete response or partial response in the 20 gray protocol compared to the one in the 10 gray protocol. So, perhaps the 20 gray in 4 fractions that that protocol is actually a bit more, I would say, efficient in helping to stop the sialorrhea or for at least 6 months. So you can see here that Botox is about 3 months, and then radiation therapy can be about 6 months or a bit more than that, the efficacy, failing which after that they may need repeat therapy. There's also this very small study about gland and salivary duct photocoagulation, which is a minimally invasive technique that was used to reduce sialorrhea in children affected by cerebral palsy. So it's using laser light and via a catheter introduced through the parotid duct, but it has not been tested in ALS. So it's something to think about, but it has not been tested in ALS previously. The last one, okay, that is actually not recommended or discouraged in the 2012, society, the European Federation of Neurological Societies clinical practice guidelines. So it's discouraged because mainly, as we know, again, ALS is actually, we don't recommend, and they may not be able to tolerate, for example, their vital capacity may not be able to tolerate surgical procedures. So it has not been really investigated with respect to ALS. So there are a few methods. So one would be a neurectomy of the tympanic plexus as well as the tympanic cord. Okay, and the other one is called Wilkie's procedure. It's actually a surgical procedure whereby, okay, they actually reposition the parotid ducts. Okay, the normal opening of the parotid ducts are actually into near the second upper molar of your oral cavity. So if you reposition it into the tonsillar fossa, along with bilateral submandibular gland resection, that's actually the Wilkie's procedure. Again, we haven't really tested it in ALS. So that's all I have for my side. So please do post questions if you have any. I'll pass the time back to Mr. Bala for him to continue his session.
Thank you, Dr. Deborah. So I'm just going to start from where I left. So we were measuring the PCF, and then we had some understanding. Based on the PCF, we will decide whether to do an intervention which is needing advanced cough technique or just continue with the normal technique. So let us focus on the first part. When the PCF is a little bit normal, the cough is intact, and the patient is managing his own secretions. What can we do for these patients? So this is knowing that the patient has intact cough. Okay, so how can you help this MND patient? So I've divided my secretion management into 2 arms. So if it is intact, right, what all you can do, and if it is impaired, what you all can do. First, we will focus on the intact cough. So these are all very basics. I'm just trying to share this. For some people, you already know. For others, it may be an information now. So first step in any secretion management is postural drainage. I just put an apple here just to make sure you're all awake here, because it's a long session. I don't want to put text anymore. So postural drainage is basically gravity. It's using gravity to drain secretions. So that's how postural drainage works. It was discovered in 1904, and then it is still working for all the patients now. And this is one technique I cannot really see a contraindication. Most of the patients, right, we should be able to apply this technique, and it is very, very, very powerful and very useful. So it's basically gravity, and I put the airway here. So you can see the orientation of the airways here. The upper lobe, the airways are like this. The middle lobe is more horizontal, and the lower lobe is vertical down. So if I want to apply this postural drainage for these patients, right, I need to position the patients accordingly now. So if it is upper lobe, right, maybe I can have some participation here. Anybody wants to say what will be my position if I want to drain the upper lobe? How do I position the patient? I know some of my friends are here, so if nobody's talking, I will just call my friends out. Anybody can just say, because I want it to be more interactive. Otherwise, because Dr. Low has requested me to be very practical rather than just making it very theory. That's why I'm asking. Anybody wants to say how I position if it is to be upper lobe? If I want to drain my upper lobe, how do I position my patient? I've given you a clue here. The airway is facing upwards. How do I position the patient?
Mr. Bala, someone said it's lateral.
Okay. Lateral. Okay, I will agree with lateral. Can you add on? So then lateral, okay. Anything else you want to add on to lateral? Okay, I will go on. So it's more propped up position. If you can just understand, the airway is like this. So you need to prop the patient up for your upper lobes to be drained. And you can turn them laterally after you prop them up a little bit. Okay, propping up is very important if you want to drain upper lobe. For middle and lower lobe, right, it's more flat lying and then turning to one side. If you really want to drain the lower lobe, right, for some patients, you head down tilt. If you can understand, if you head down tilt, your lower lobes can be drained. So just want to give you this idea how to drain different lobes. And again, the head down tilt may not be tolerated by NMT patients. So, and not only NMT patients, for a lot of patients, it is not being tolerated. So we don't advise head down tilt if the patient doesn't tolerate. Even lying flat and turning to one side will help lower lobes. Okay. Everybody clear about postural drainage? Later, I have a video. We can watch the video now. I just wanted to make sure you all understand how to position your patients based on the lobes. So, for example, I give you a practical situation here. You go touch the patient and you see a lot of perimeters in the upper lobes. And the patient is lying flat. So straight away, what you can do is you can prop the patient up and then you can continue your techniques from there. So first part is positioning the patients so that the drainage can happen, and then add on your techniques so that the phlegm can be cleared. Okay, so that's what I want to tell you about postural drainage. I'll go to my second slide. So the second technique, right, which is commonly used is chest percussion. If you ask anybody what is chest physio, they will say clapping. They just show clapping. This is something known universally. This chest percussion, I put this here. For example, you have a ketchup bottle and then you want to clear or just get the ketchup which is just stuck in the bottle, right? What do? You turn the bottle upside down. That's your postural drainage position. Okay, you apply your postural drainage position and then you clap at the end. So that is your chest percussion. So you clap. So the clapping at the end is your chest percussion. So when you position the patient and then you know you're draining it already, you can add on chest percussion over that. That will help the secretion to move. So basically, how does it work is it will increase the intrathoracic pressure and then it will dislodge your secretions. I will show you a video how to do chest percussion later. So that's your second step. Sometimes patient may be very fragile and they may not be able to tolerate percussion because it's quite, sometimes it is painful. So we also have this something called vibration and shaking. I put this diagram here just to make sure you all understand how to do this vibration. So your ribs move in two directions. Whether it is called as a pump handle movement, which is with your sternum, and bucket handle movement, which is your ribs on your sides. So when you're trying to do vibration, you need to follow this rib movement. You cannot go against rib movement. You have to follow this rib movement. It's always when and this vibration is done during your expiration. You don't do during your inspiration. So during your expiration, right, it has to go down and in. So whatever you do, right, whatever vibration you do, it has to be down and in. Cannot be up. Everybody will try to do up because you want to move the secretions up. You will try to vibrate upwards. But you have to follow your rib movement and it has to be down and in. Later, I have a video. I will show you how to do this also. So just to recap, if the patient's cough is intact, we follow these 3 steps. Position the patients according to the area where the phlegm is. If it is upper lobe, you prop up. If it is middle or lower lobe, you lie the patient flat if possible, if the patient can tolerate, and turn the patient. The secretion, wherever the secretion is there, right, that lung should be up. You bring that lung up so that you can drain it. And then once you position, you can start with your percussion and then you can do your vibration. Okay, I'm just going to go on. Some precautions and contraindications for the percussion and vibration. I just want to say you cannot do it on all patients. So if the patient is very osteoporotic, right, I think you should be very careful. If you're not used to, you don't know how to do this technique, I will advise not to do percussion and vibration because you can break the ribs. And if they already have chest injuries like rib fracture or metastatic ribs, again, we don't advise you to do these techniques on them. If the patient has a history of hemoptysis, coughing out blood, again, we don't advise the secretion. And the patient easily goes for bronchospasm, also we don't advise. So these are some cautions. Please don't do it when the patient shows these kinds of symptoms. Okay, now this is the video. Just want to thank Joshua. He's also here. He helped me with these videos, and this is Joshua here. So for the first one, right, if you're lying flat, if you want to drain your upper lobe, you prop yourself up. So this is the first postural drainage position. The second one, if you want to drain your middle and your lower lobes, right, you just have to turn, and then you can get a pillow just to support yourself. Okay, so that's your postural drainage position. Okay, I'm just going to go to the next one. So just to summarize, upper lobe, prop up, middle lobe and lower lobe, based on the sides you want to drain, you bring the side up and then you turn to one side. So the next technique is percussion. I just show you percussion first. So you put a towel and then it should be rhythmic. Again, once the patient is in side lying, you can do this in this rhythmic position. You can do for 30 seconds to 1 minute and then you stop and then see whether the patient wants to cough out. You cannot keep percussing non-stop because sometimes when you do that, the patient will stop breathing also, so they become breathless. So just do for 30 seconds and it has to be very slow, not hitting. The sound is very important. If you are hitting a person, you know how the sound is. If you're cuffing a person, you know how the sound is. It has to be cuffed. Your hand should be cuffed nicely, and then the sound should be very nice. It cannot be hitting like that. Okay, it is very painful. You have to be very careful. You can practice on a pillow. So the next one is vibration. I'm just going to show you this video now. So down and in. Okay, you allow the patient to breathe in, and then during expiration, you go down and in. Okay, and down and in. Okay, so that's how you do. So you can do it in side lying position, and sometimes you may have to do this in spine position. It has to be done like this. Yeah, down and in. Okay, to follow the rib movements. Okay, so this is vibration. Okay, so these are some techniques you do, and on top of that, if the patient has some control, we can teach ACBT. This is called active cycle of breathing technique. It consists of 3 things. One is breathing control, which is like breathing normal tidal volume, and then you keep your hands at the sides, and then you ask thoracic expansion exercise. So the second one is make sure the patient breathes a little bit deeper. And the third one is making sure the patient can cough. FET, forced expiratory technique. FET is either huffing or coughing. So again, we can only use this if the patient has a good cough. The cough is intact for the patient. If the cough is weak, that's where we need to switch on to the second one, which we'll be discussing later. So all these techniques, whatever I'm sharing, is a patient is able to have a good cough. So I'll just show you what is FET. FET is basically huffing or coughing. So this diagram, I liked it. That's why I put here. Sometimes your cough is very powerful. It can get your lung out of your system. So that is cough. But you know, here we are dealing with a patient who has a very weak cough. So when you open the glottis, so that is huffing. When you do with closed glottis, that is coughing. So sometimes you should decide which one is more suitable for the patient. You can either use huffing or you can use coughing. Something I want to highlight here is, right, coughing has another value. When you do coughing, it works on this two-phase gas-liquid mechanism. What does that mean? Means when air is flowing over a solid substance, it will reduce the viscosity of that, which is your phlegm there. Air is the cough, and it also reduces the surface tension, and then it will allow the secretion to move up. This happens with coughing. So when a person is having weak cough, right, it is very difficult to clear secretion because we also lose this two-phase gas-liquid mechanism. Because the secretions are a little bit adherent, and for them to move, we not only need that power, but we also need this reduction of viscosity and reducing the surface tension, which happens naturally with a huffing or a coughing. Okay, just wanted to highlight that two-phase liquid mechanism. So this is your FET. I have a video. I just have to escape and then share the video. Give me now. Okay, I'm going to share now. Okay, so this is ACBT. Yeah? Okay, I'm just going to play the
Step
video.
approach. Step 1. Position yourself comfortably in your bed. We would recommend you to be in a more upright position. Step 2. Place your hand on your stomach and take in a slow deep breath through your nose. Feeling your breath expand your lungs.
This is your breathing
Then
control.
gently breathe out through your nose and repeat these 3 to 5 times. Step 3. Breathe in through your nose, filling up your lungs, and hold your breath for 3 seconds, counting 1000, 2000, 3000. Then slowly breathe out through your mouth. Repeat this 3 to 5 times. A short duration of breath holding helps to open more air sacs in your lungs and also move secretions for easy clearance. Step 4. Take in a normal breath and force the air out through an open mouth as shown in the video. Repeat 2 to 3 times. Step 5. Take in a bigger breath and force the air out quicker than in the previous step. Repeat 2 to 3 times. You may experience phlegm coming up. When clearing phlegm, face away from others. Hold your phlegm in a tissue before disposing it. Step 6. After clearing your phlegm, continue normal breathing. Breathe gently in and out through your nose. If you feel there's more phlegm to clear, repeat the steps again. You can do this as frequently as you like to help with the clearing of phlegm.
Okay, I'll just stop here. We'll go back to these slides. Okay, hopefully that was very clear about ACBT. So we will go on. So now I'm going to take you to the next part. So now example, if PCF is less than 270, so we know the cough is not intact. What do we do to help this patient? So as indicated here, LVR is your first step. So we will just see how we use LVR. So I've shared this with you. Cough has 3 steps. One is inspiration, then expiration, and then augmenting both. First, we need to augment inspiration. So if you can augment inspiration, sometimes the cough is improved already. So we start with inspiration. There are many ways to augment inspiration. The first common way is lung volume recruitment, which is called as breath stacking, glossopharyngeal breathing, volume controlled ventilator, mechanical insufflation. You can use the cough assist machine. The component of insufflation can be used to breath stack, or you can, if lung volume recruitment is not available, you can use a normal manual resistor bag to inflate your lung. These are different ways. Today, we'll be discussing more about LVR and glossopharyngeal breathing. Just want to show you the circuit of LVR. So this is your normal resuscitator bag. You have a connector, straight connector. This is corrugated, and then you have a connector here. Then you have a one-way valve. This is the most important thing. So air only goes in one direction. It goes in this direction, but it does not come out. So to start off LVR, right, we want to measure the pressure which is in your lungs. So at this point, right, you have a filter here, and then you use this gadget, which is manometer, and then you can check what is the airway pressure which is developing there, so that you know whether you're building up enough air. This is for the first time. After you know this patient is able to tolerate, and then it's not going very high, then you no need to use this. When you start off LVR, we sometimes use this gadget to see what is the pressure like in the air. And then this is connected to your patient using a face mask. Initially, for demonstration purpose, this is a model lung. We use this just to see how much the pressure is developing. So this is how the circuit is for LVR. So just go through one more time. Corrugator tube, one-way valve, there's a connector, and then a one-way valve. And then this is a monitoring device here. There's a filter which you use to connect to the manometer. And then you directly connect to the face mask. And you can apply to the patient. Okay, so this is your LVR circuit. So what is LVR? LVR is basically stacking your breath. So we use the word called MIC, maximal insufficient capacity. This can happen only if your bulbar system is working and you can hold your air and then you can stack up your air. So I'll just demonstrate. You breathe in, hold, and then breathe in again, hold, breathe in again. So this has to be coordinated with that bag so that you can build up that MIC. So when you are able to build up, definitely your MIC is going to be greater than your VC. So this is how you improve your lung volume. So directly, there are benefits. If you increase your lung volume, your atelectasis is going to be reduced. Because if NMD patient, we all know respiratory muscle weakness is there. So the peripheral airways are going to collapse. There's going to be atelectasis, which can be overcome with LVR. So this is the mechanism how it helps cough. If you expand your lung bigger, it's because natural mechanism is elastic recoil. So if you expand more, it recoils better. So that recoil helps to clear secretions. That's how the cough is enhanced with LVR. Also improves your compliance of the lung because if you see NMD patient, right, constantly their breathing is going to be on a lower volume, and that indirectly affects their thoracic rib movements, and their range of motion of the thoracic wall is going to be less. With LVR, right, you're artificially trying to keep that compliance of the thorax. So that is also going to be better. So if you don't do this right, later, if you want to increase the volume, you don't have that compliance in the chest wall. So it's going to be affected now. So that's why LVR is very important to start early so that you can maintain that thoracic compliance. And so you can artificially increase their vital capacity. And it also helps in their speech because, you know, speech depends upon the volume in your lungs. So if you increase your lung volume, the speech also gets better. So these are some benefits of LVR. Some precautions just want to highlight. This is more applicable in a hospital setting, but in a home setting, if the patient is on trachea, just make sure the is not being useless. So do not use on endotracheal tube and cuff trachea. Because once the patient is on trachea, if you use LVR, it's like a one-way valve. So the lung is going to pop up. You can use it in an uncuffed trachea, but I will advise you not to use. It should always be used through your face. That's the recommendation. So that's one thing I just want to tell about LVR. Again, some other contraindication like severe COPD, the patient has history of emphysema, hemoptysis, hypotension, so we don't use LVR. Okay, so these are some practical points about LVR. So you squeeze 2 to 3 times or 2 to 5 times per repetition, and then you can repeat this 3 to 5 repetitions per session, and then you can do this 2 to 3 times a day. The second point is sometimes LVR is sufficient on its own, but sometimes we add MAC with LVR. After you do LVR, when the patient is about to cough, you can add your manually assisted cough. LVR can be done either with a mouthpiece or a face mask. Just want to share some evidence. I know the time is 39. I'll just quickly go through this. As I said, LVR can be done only if the bulbar is intact. So most of the studies are done with Duchenne muscular dystrophy and spinal cord injury patient. And they found with LVR, you can really increase your PCF. So I just go to this diagram here. Baseline is around 170, 160, 170. With chest compression alone, which is manually assisted cough, you can increase it to around 230. But with air stacking is same. But if you combine, right, you can go up to 300, almost 300. So you can see from baseline 150, you are going almost to 300 with the combination of air stacking and chest compression. So that's how useful lung volume recruitment can be for these patients because they cannot generate that volume on their own. So their peak cough flow is affected. If you can generate that inspiratory volume with air stacking and then combine that with the manually assisted cough, the peak cough flow is very good. 300, right? Then you solve your problem. So there's no retention of secretion. The patient can clear the secretions very easily. So that's how LVR is going to be useful. So the second study is a spinal cord injury patient, tetraplegia. Again, we get the same kind of information. Baseline is around 160. And when you combine manually assisted cough with air stacking, you can increase your peak cough flow. It's going up to 370, 360, 370. So definitely the peak cough flow is increased with LVR as well as manually assisted cough. Again, spinal cord injury patient, the vocal cord is intact, so it's working very well. So the question now is, right, how about NMD patient now? So they studied this in NMD patient, and then they found MAC is manually assisted cough and manual insufflation now. Definitely, they are a good determinant for NMD patient also. So if you add on LVR as well as MAC, and if the vocal cord is intact, it helps them also for NMD patient. So these are some evidences there already existing for LVR. Improving cough in NMD patient. So that's the conclusion of this article. The other article which I just wanted to share is, right, how about lung function in general? What they found is, right, with LVR, the decline in the lung function is reduced. Once you start LVR, right, you can see this sharp decline in lung function is reduced annually. So that's what they have found, not only increasing the PCF, but the lung function as a whole is not declined after starting LVR. So lung volume recruitment is quite useful for muscular dystrophy patients. Next is glossopharyngeal breathing. This is very difficult, but I just want to introduce here. Just moving this away, I cannot see. Glossopharyngeal breathing is also called frog breathing. It was first discovered in poliomyelitis patient. So they saw patients gulping air. So basically, you open your mouth and then you take air and then you swallow that air and push that air into open glottis into your lung. So you do that. It's very difficult. I think somehow patients learn it very easily. Poliomyelitis patients learn this naturally. And some of the NMD patients also have this ability to do frog breathing. It is similar to LVR. We are trying to increase lung volume. It is on par with LVR. Sometimes if they do it very well, their inspiratory volume can be increased and the MIC can be very high. So that's how frog breathing can be very useful. You can make an attempt to teach this to some of the patients. That's frog breathing. Again, there are some practical points here. It definitely helps in secretion clearance. If they learn this very well, and then you combine with manual assisted cough, secretion clearance is much better. This is some evidence, but we will just go to the next one. The last one I just want to share, right? We were talking about bulbar involvement here because for breath stacking, we need a bulbar to be intact. But how about when the patient doesn't have a bulbar? There's some impairment in their bulbar system. So what do? Do we do lung volume recruitment with them or we don't do? The guidelines says that even with bulbar involvement, right, use single maximal insufflation technique for patients with bulbar dysfunction who are unable to breath stack. So again, the recommendation is, right, even with bulbar involvement, you can go one full volume now and then see whether that helps in their PCF, peak of flow, and then combine that with the manually assisted cough. Definitely, it is very useful for a patient who has bulbar system intact, but even with bulbar system being impaired, we can still try one breath. So that's what is the recommendation. So again, I have a video. Okay.
Lung volume recruitment with a modified manual resuscitation bag. The LVR bag is used to assist with breath stacking, beyond that which an individual can achieve on their own up to maximum insufflation capacity. Routine lung volume recruitment with the LVR bag benefits individuals with neuromuscular diseases, spinal cord injury, or musculoskeletal conditions such as kyphoscoliosis. Most importantly, use of the LVR bag will increase lung volume, improve cough effectiveness and secretion clearance, and/or simply assist to clear nasal passages. Be mindful that the LVR bag is not an emergency resuscitation device. If used for resuscitation with a full face mask, the LVR bag one-way valve will not allow the individual to exhale and may cause a tension pneumothorax. When first using the LVR bag, it is recommended to be familiar with the kit's contents. The LVR bag consists of the following essential components: one manual resuscitation bag, one 50 cc large bore tubing to allow for maneuverability, one single one-way valve with a caution indicator. This one-way valve assists with breath hold in conditions with weak upper airway. The one-way valve capped port can be used to add a pressure manometer. Then there's a screen connector to trap the unidirectional silicone piece should it become dislodged from the one-way valve connector. And lastly, a mouthpiece with or without an added connector, which will be dependent on the type of mouthpiece used. Nose clips are optional and should be used if the individual is unable to close the soft palate or when air escapes through the nose during breath stacking. To assess the clinical benefit of LVR bag therapy, measure and compare forced vital capacity with and without the LVR bag. Brad's forced vital capacity without LVR bag is 0.9 liters, 17% of predicted normal. The forced vital capacity is then repeated using the LVR bag. Brad's MIC lung volume is 3.2 liters, 64% of predicted normal. The use of the LVR bag for Brad results in an MIC-VC difference of 2.34 liters, a significant lung volume recruitment improvement of 260%. The ability to produce a strong cough is critical for secretion clearance with individuals who have weak inspiratory and expiratory muscles. Hence, it is essential to measure and compare peak cough flow with and without the LVR bag. To demonstrate the procedure, Robert volunteers to perform his best spontaneous peak cough flow, 60 liters per minute. The peak cough flow is then repeated using the LVR bag, breath stacking to maximum insufflation capacity. Robert's peak cough flow with LVR bag increases to 210 liters per minute. When Robert combines breath stacking with the manually assisted cough technique, his peak cough flow significantly further improves to 310 liters per minute, well above the recommended peak cough flow of 270 liters per minute required for effective secretion clearance.
Okay, I'm just going to continue. So that's about LVR. And I'm just going to go to the next one, which is assisting expiration. So assisting expiration, we all use manually assisted cough. So there are different ways to do this. Either you can use your chest wall or you can use your abdomen here as well as your chest wall. So there are some variations according to the patients. One thing I would just want to say, right, if there is a PEG placement, because normally we encounter patients having PEG, so you can either go costal. So for those patients, you can use your costal area to assist with your expiration. Sometimes we cannot use the abdomen because of the PEG. So that's how it is. And I have a video for you how to do this. This is, you breathe in and then this is using abdomen. Okay. So that's how you do a manually assisted cough. You allow the patient to breathe in and then you just coordinate during the expiration, and it has to be quite powerful. Otherwise, the phlegm cannot come out. That's how you do manually assisted cough. Okay. So now the next part is how do we augment both? If you follow that flow, initially we try LVR, then we combine MAC, manually assisted cough. If both doesn't work right, that's where you need to combine a different one, which is inspiration and expiration. That's where cough assist comes in now. Just a brief history about cough assist. It was first discovered in 1950 from the tank respirator setup. So this is used during polio also to create negative pressure. That's where this cough assist concept was discovered. In 1952, they created a coughflator. The F is missing here, typo. And then it was just disappeared from the market because we had this positive pressure ventilation, and tracheostomy was discovered around that time. Somehow people didn't need any device to take out the secretions. But in 1993, again, it was coming back, and then that's where the Philips cough assist, what we have now, was coming to the market. And basically, it works by this two system, two-stage centrifugal blower. It applies a positive pressure and then rapidly shifts from that positive to negative. So this shift from positive to negative simulates a cough, and it is able to produce a cough which is kind of a real cough and is able to clear secretions. So that's how cough assist was discovered. This is the journey of cough assist, and now cough assist is being used for most of the patients, spinal cord injury patients, NMD patients who have impaired cough. So this is the definition of cough assist. A machine that stimulates a natural cough by gradually delivering a large volume first to your lungs, similar to normal breath. When your breath is in and then quickly reversing the flow to pull the secretions out, then it suddenly shifts to negative pressure. So that's how cough assist works. I know we have a mixed audience, so I've just taken this opportunity to introduce the cough assist. Some may know already this, but I just quickly go through. If you switch on the machine, right, this is the screen you will see in a cough assist. So that this is where you set your settings. And when you set your settings, you can use this device to go up and down, like increase or decrease your settings. And this is where once your setting is all done, you want to start therapy, you press this. So if it is standby, means the machine is not working. Then you press therapy here, then it will become into therapy, then it is working. To switch on the machine, you have this on and off machine, and this is the manual control. Sometimes you want to use manual control. Just now I said if you want to use LVR with a cough assist, right, you want to only use insufflation, you use manual control. You set up and then use the manual control to insufflate, and then the patient can take in a deep breath. This indicates your battery, and this indicates whether the machine is in standby or therapy, and these are your patient settings. At the back, you have air outlet, and then the pollen filter is here, and the battery is here. This is the battery detachable battery, and this is the charging cord and oxygen connector. These are some of the gadgets or the accessories we use when you use cough assist. This is the trachea mount, and then this is the face mask. This is the connector, corrugator tube, and filter. So all these are required when you're using cough assist. This is how the connection looks like. If the patient is on an ETT or a trachea, right, you have this trachea connect here. If the patient is through NIV and you are using through face mask, the connectors with the face mask. The interface can be either a connector which connects to the trachea or a face mask which connects to the face. So when you switch on the machine, right, the settings come up. You have to design your settings. I'm just going to spend some time on this. So you choose whether you want to do a manual or an auto, and then cough track. Cough track is very important. I'm just going to mention this a little bit later also. You need to set up cough track whether it is on or off. The recommendation for NMD patient, right, cough track should be on so that the patient can initiate the cough assist rather than the cough assist automatically functions by timing. So cough track is a way where patient has control. When the patient wants the machine to trigger the breath, only then the machine will trigger the breath. So that's what is cough track's function is. So when you start a cough assist, right, you always start with low pressure, which is +20, -20, and then you slowly increase the pressure. The question which is normally asked, right, what is the optimal pressure? The answer which is given in most articles are the phlegm should be able to come out into your tubes. That is your optimal pressure. But having said that, the patient should also tolerate that pressure. So you've got to balance that. You need to make sure the patient's BP doesn't drop by increasing the pressure too much, but the phlegm is coming out, but the BP is dropping. So then you may have to be working in a balance where it doesn't affect the patient's medical stability. But the optimal pressure is when the secretion is able to come out. So that's the optimal pressure, but you start with a low pressure first. And insufflation exsufflation time is usually 2 to 3 seconds. And something to note is the exsufflation time should be less than or equal to insufflation time. It cannot be more than insufflation time. So that's based on an article study. And it also has oscillation. So oscillation is airway oscillation. It will reduce your viscosity of your secretions. And you can set this oscillation, and it mimics percussion or vibration. So that's your cough assist setting. So the next step is if you set already and then you want to start therapy, you just have to press this and then the machine will start. So standby means the machine is not working. Once you press this therapy, it will change to standby, and then the machine is already working. So this is how you know whether the machine is working or not, whether the patient is triggering a machine or not. If the patient triggers, it will start inhale. The blue thing is the inhale, and your yellow thing is your exhale. So one rep is, it completes this blue and yellow. And then one set can be 5 reps or 3 reps based on the patient's tolerance. So that's how you calculate. Okay, so this is about repetition and sets. Then if you want to stop the treatment, you have to press standby. Once you press standby, you can see a display here, standby, then the machine is stopped. So that's how you stop the machine. I know the time is running. I just finished this fast. Maintenance of cough assist. So this one, right, I think can continue for some time until unless it is spoiled or very significantly soiled. You need to change it, but you can wash and use it. But this corrugator tube, we recommend you to change every month. And you can wash this, and this one filter, right? You cannot wash, please do not wash, and then change this every month. So that's some recommendations we have for you. This pollen thing, which is at the back I showed you earlier, also can be washed and then dried and then can be used and can be changed every 6 months. And battery, please don't overcharge it, and make sure it is fully charged, because it is very important, the thing to work. Now I said, what is the value, optimal value? One of the authors did the study whether whatever the manufacturer says is true or not. They found this sweet spot here. If you have an inspiratory pressure of 30 inspiratory and minus 30 expiratory, and inspiratory time 3 and expiratory time 1, right? You are getting a good expiratory flow here. But if you have the same time, right, the expiratory flow somehow is not optimal. So what they recommend is try to reduce your expiratory flow, expiratory time compared to your inspiratory time. Then you get your peak of flow better. As you go up, as you increase your pressure, you can see obviously the expiratory flow is much better also. But the sweet spot is 30 minus 30, 3:1. So that's the sweet spot based on this article. Okay, whatever the manufacturer says, it is true. That's what this article proves. I don't have time, but I'm just going to just briefly share this. Cough assist, they tried on many patients. For COPD patients, right, they found cough assist is not very helpful. If you can just follow this COPD here, their baseline normal cough, right, is 370. But if you do manual insufflation and manually assisted cough, right, their peak expiratory flow falls. This is because of the dynamic airway collapse. But in NMD patient, you can see the significant increase in their peak cough flow. So NMD patients, manual assisted cough as well as cough assist can work. For COPD patient, you have to be using this very carefully. Okay, just show this and then go on. Because of the dynamic collapse. So now the next important question to answer is, right, for NMD patient with bulbar involvement, whether cough assist can be used, whether cough assist can be used. The first person who answered this question is Sancho. What they found is, right, they found dynamic airway collapse with cough assist, but they gave this recommendation: am I able to increase peak expiratory flow or peak cough flow, both with and without bulbar dysfunction, except for those bulbar dysfunction who have MIC greater than 1 liter per second and a PCF MIC less than 2.7 liters per second due to dynamic collapse of the upper airway. So they said if the PCF MIC is less than 2.7, right, then there's airway collapse. So cough assist may not help them. So that's what they found in their study. And this problem was lingering. And then that's where Tina Anderson, who has come up with this study, and then she tried to understand what happens with this bulbar patients when you do cough assist. She wanted to answer whether cough assist is useful or is there a problem using cough assist with this bulbar patient. I'm just going to show this video now. You just watch the vocal cord here. Insufflation. This is normal bulbar. Insufflation is open, okay? Insufflation, it's open, and then during exsufflation, it is closing. So no issues. Insufflation, it's opening, and exsufflation is closing. So with normal bulbar cough assist, no issues at all. This is with the bulbar involvement. You see, this is insufflation. You see that it's insufflation and it's closing. Yeah. So when there is bulbar involvement, right, with insufflation, you can see the bulbar is closing. Okay, so this is what Tina Anderson found for us, and this is very, very useful for us. I'll just share what is her recommendation based on this finding. So what Tina Anderson found is, right, there is a very big problem when the bulbar is involved. During insufflation, the vocal cord closes. So when it closes, right, the air cannot go into the lung. So it is not useful at all. So she came up with this recommendation if the patient is having bulbar involvement. For laryngeal stability, right, she asked us to use low inspiratory pressure. So this low inspiratory pressure should be similar to your NIV. No? For example, if you're using NIV and you're using inspiratory pressure as 20, then you can just follow that. That will be a good gauge. The patient should be able to adapt to that kind of pressure. So that's the low inspiratory pressure. And low airflow and longer inspiratory time. She also recommends longer inspiratory time. She went on to say that she also used this physiology. Every time we try to initiate inspiration, our vocal cord will open. So that's the normal physiology. So she tried to apply this in these patients. So she said, if the patient is triggering their cough assist, when the cough track is on, then the chances of vocal cord to open is high. So try to use cough track when using a patient with NMD with bulbar involvement. So two recommendations, low inspiratory pressure and cough track to be on to avoid that closure of that vocal cord. So that's Tina Anderson's recommendation. I will skip this because we don't have time. So I'm just going to pass the time back to Dr. Deborah. Now what she's going to talk is how to apply this airway clearance technique if a patient is on NIV and trachea. Okay, Dr. Deborah, all yours, Dr. Deborah.
So this is from the excellent article by Chatbin et al. On airway clearance in neuromuscular disease. And you can see that for stacked breaths, one of them we look at is volume cycled NIV. Okay, so I'm just going to share a few articles. They are not directly related to patients with ALS or MND, but I just wanted to let you all have a look at it as well. And so this article actually compares a resuscitator bag versus mechanical ventilation. So as we know, MIE may not be widely accessible in countries with some limitation of healthcare resources. So this was actually a prospective parallel group study with adult patients more than 18 years old, as well as Duchenne's muscular dystrophy, requiring NIV that is volume cycled at a Center for Home Mechanical Ventilation, Belgium, in a 2-year period. So they were actually taught and trained for 2 minutes in both air stacking techniques, home ventilator and resuscitator bag, and then randomized to either technique. So after air stacking, they will cough with forced expiration into a mask that was held by the therapist. So air stacking via the home ventilator performed using volume cycled HMV and a nasal mask interface with the parameters unchanged from those that were used for nocturnal NIV. Then they also did air stacking via a resuscitator bag conducted by experienced physios using a 2-liter bag as well as a full face mask. So they found that actually 27 of them underwent air stacking via their home ventilators, 25 via manual resuscitator bag. And there was actually no difference in terms of the air stacking assisted CPF or the cough peak flow. Okay, and also you can see here that for the cough peak flow, right, there was actually I mean, this just shows individual improvements in the cough peak flow and the volume with the air stacking assisted cough. So A and B. So A would be the assisted cough peak flow with the resuscitator bag. B would be the assisted CPF with the ventilator. C is the assisted volume, the resuscitator bag, and D is the assisted volume with the ventilator. And there's another study. So again, in all these studies, the glottis was actually competent. So they didn't really have any bulbar dysfunction, which, as we know, is it tends to get more common as ALS progresses. And also there are patients with bulbar, at least 30% with bulbar onset ALS as well. So for this, what happened was actually the glottis was competent. And also the volumetric ventilation mode is actually required. And the total insufflated volume is actually sometimes maybe a little bit difficult to adjust based on the tolerance in, for example, in neuromuscular diseases. So for this study, it was a randomized open single center kind of a study. And it compared 2 inspiratory cough assistance techniques, which is the VCM, the volumetric cough mode, as well as breath stacking on a home ventilator. So inclusion criteria was that they had to have NMD, home NIV with volumetric mode, and no previous experience with cough assistance techniques. hemodynamically stable and absence of acute infection, bronchial congestion in the past month, and with a CPF of less than 270 liters per minute, or MEP less than 45. So there were 20 subjects with NMD, okay, and they were recruited during follow-up visits at the post-intensive care unit. So on the day before the test, subjects were familiarized with the ventilator that was actually equipped with VCM. So this is actually a special mode that was actually available on the Astro 150 ResMed France. So so for the thing is that for this particular study, the mechanical ventilation is modified such that you allow a 500% increase in the tidal volume and can be used in volumetric mode for both VCM and breath stacking. But actually in the usual, okay, I noted that actually for the Astro 150, not all devices have this volumetric cough mode. And for volumetric cough mode, sometimes the maximum they will allow is a 250% increase in VT. So for this study, there was a bit of a bias because they actually allowed the VT to increase up to 500%. So for breath stacking itself, okay, what they did was actually the usual breath stacking with the on a home ventilator. So they instructed the subject to perform consecutive inspiratory whole insufflations until the lungs felt fully expanded, producing a stretching sensation across the chest, or until the insufflation pressure plateau was about 50 cm H2O. And so this first exhalation after the augmented insufflation was used to cough. But for VCM, or volumetric cough mode, there was intermittent inflation of the lungs with a volume greater than the baseline tidal volume. So the hyperinsufflation cycle was actually automatically repeated after 30 seconds of the usual cycles. So an audio signal was sound just before the deeper breath to alert the subject. And this intermittent deep breath that began at about 110% of the baseline VT, then was volitionally increased by 10% increments until the insufflated volume actually reached the highest tolerated value of 500% of the baseline tidal volume, okay, or until the max pressure reached 50 cm H2O. And they did find, okay, you can see here that there are many different types of NMD, including DMD, then spinal muscular atrophy, as well as a lot of others. And basically, they actually perform both techniques in a random order. And the CPF was actually always lower without than with the mechanical cough assistance. And in 16 subjects, the CPF was higher with the volumetric cough mode than with breath stacking. Breathing comfort and subjective cough effectiveness was actually similar with both techniques. Okay, so this was actually what I wanted to show, and you can see that the cough peak flow with the VCM was highest, okay, compared with breath stacking using your usual home mechanical ventilator. Okay, and how can we apply this knowledge? So basically, breath stacking using a volume cycle NIV device is possible, okay, with spinal onset ALS, but it may be more challenging with bulbar onset ALS or in the late stages of ALS because of the lack of glottic control. Sometimes you may consider using an LVR bag with a one-way valve or cough assist device with an abdominal thrust at the start of exhalation at least once a day, preferably about 2 to 3 times a day if they can tolerate. You can see from this study that with an optimized BiPAP and cough assist protocol, okay, they managed to actually live until about 30.8 months with a normal standard BiPAP as well as cough assist is about 26.3, with a standard BiPAP protocol is about 15.3, and with no intervention was about 13.7 months. So this is a very good systematic review about how they troubleshoot, they did troubleshooting of NIV problems. And you can see that again, excess respiratory secretions, there are not many studies. Okay, so they actually use adjuvant cough assist devices. Some of them switch from pressure NIV to volume NIV, but these are all case series, case reports. And the excess oropharyngeal secretions, they use the sub-Q glycopyrrolate infusion, the study by Cooper Knock that I mentioned previously, whereby they gave 600 micrograms of sub-Q glycopyrrolate over 12 hours. Okay, so that's only a case report evidence from what I can see so far. And of course, for the other problems and solutions, I won't touch on this because I think there will be a talk on NIV in ALS, but there were quite different types of evidence available, mainly retrospective. So a very small note on mouthpiece ventilation. Okay, I know everyone's getting very tired. I know that mouthpiece ventilation may not always be available. Okay, but basically there was this study that actually showed that with with a BALS FRSR score, okay, if it's more than 6, right, then actually they were able to use MPV for lung volume recruitment, as well as continuous non-invasive ventilation. Okay, but and if let's say the peak cough flow with the lung volume recruitment was more than 180 liters per minute at the initiation of MPV, is actually associated with a longer survival, as you can see from that Kaplan-Meier curve over here on the right side. Okay, so 30 of the successful subjects were actually able to generate MIC minus VC with the lung volume recruitment. So they could generate that difference, 30 of them. Okay, and this is just some of the recommendations from Ken Van with regards to mouthpiece ventilation with a volume cycled pressure or flow triggered HMV. All right, and usually most of the time alarms are off, except for perhaps the apnea or circuit disconnect alarms. Okay, and for the tidal volumes, you may set the VT larger than the spontaneous VT, so you can enable lung volume recruitment to the maximum insufficient capacity within 2 to 3 stacked breaths. Okay, and now we have different modes, different HMVs like Trilogy Evo, Trilogy 200, they carry the MPV mode as well, MPV PC as well as MPV VC. Okay, so that was all I wanted to share. And then, of course, while on tracheostomy, MIE can also be used, okay, but it's according to Ken Van, it's best to perform MIE with inflated cuff to minimize leak, as well as to enable the chest to reach therapeutic pressures. So you also want to briefly deflate this tracheostomy cuff prior to therapy, so secretions can actually drop from above to below, and then subsequently you need to use the MIE. Okay, so use of MIE with a cuffless tracheostomy is actually possible, but the stoma should be relatively tight around the tracheostomy, and the patient should actually have good control of their vocal cords. So again, patients with predominant bulbar onset ALS may experience some difficulty with using MIE while on tracheostomy, but it is still possible. Okay, and you can also actually use MIE to help with just lung volume recruitment, and do it about 2 to 3 times a day for at least about 3 to 5 cycles each time. And each cycle will be, of course, there will be, so each set will have the insufflation exsufflation cycles at least 3 to 5 times each time.